Today, we will be discussing gender dysphoria in children.
To define and better understand what gender dysphoria is, we can begin by breaking it down into two parts. Gender is defined as the social and psychological aspects of being male or female. It goes beyond one's biological sex, and it includes a person's understanding and meaning attached to his or her own life of being male or female. Dysphoria is a state of feeling very uneasy, unhappy, or unsatisfied. Combining the two words, gender dysphoria is an inner state of being that is characterized by the discomfort of one's assignment as a male or female. The individual identifies with the opposite assigned gender, meaning the gender they're born with, and their distress stems from the misalignment of their perceived true self. Considering the social and psychological aspects of non-conforming to their assigned gender. Previously categorized as gender identity disorder and updated in the DSM-5, gender dysphoria clarifies that identifying as a gender different from the one of your birth or being transgender is not in itself a disorder. This is a very important concept to understand. It is possible for one to identify with the opposite gender they are born with, or be gender non-conforming, without having the distress that delineates the clinical impairment that is found in gender dysphoria. For children with gender dysphoria, the impairment is clinically significant in social, academic, or other important areas of occupational function. The causes of gender dysphoria are currently unknown, but genes, hormonal influences in the womb, and environmental factors are all suspected to be involved. Identifying the differences in gender and its behavior begins in the early stages of childhood. Atypical gender behavior can be a normal part of child development. There are two types of gender dysphoria. Early onset type, which is gender dysphoria in children, may appear between the ages of 2 and 4, where cross-gender behaviors begin. Late onset type applies to adolescents and adults, where gender dysphoria may occur around puberty or later on in life. It is important to note that while a child, adult, or adolescent may show signs and experience the criteria of gender dysphoria, it does not mean that it is a lifelong occurrence. The DSM-5 distinguishes different criteria for diagnosis of children versus the diagnosis of adolescents and adults. The DSM-5 criteria of gender dysphoria in children involves an associated significant distress or impairment in function lasting at least 6 months and is shown by exhibiting at least 6 of the following: a strong desire to be of the other gender or an insistence that one is the other gender, a strong preference for wearing clothing typical of the opposite gender, a strong preference for cross-gender roles in make-believe play, a strong preference for toys, games, or activities stereotypically used or engaged by the other gender, a strong preference for playmates of the other gender, a strong rejection of toys, games, and activities typical of one's assigned gender, a strong dislike of one's sexual anatomy, a strong desire for the physical characteristics that match one's experienced gender. It is important to note that these are largely subjective. Just how strong is a strong preference? It's left up to the clinician's judgment and leaves some wiggle room for different clinicians to disagree.
Many youth face a variety of issues that affect emotional and psychological well-being. Very often, children with gender dysphoria experience levels of stigma which could lead to verbal and physical violence that will in turn affect psychological well-being. This often leads to depression and/or anxiety. Other common comorbidities might be depressive disorder, specific phobias, social withdrawal, or adjustment disorder. A recent study found that gender variance during childhood was a risk factor for experienced childhood physical, psychological, and sexual abuse. Moreover, children with gender dysphoria predict an increased risk of lifetime post-traumatic stress disorder. Some general precautions for children with gender dysphoria is that they may experience teasing and harassment at school, as well as social rejection. Children also have an increased risk for depression, anxiety, and social withdrawal. Adolescents with gender dysphoria are at an increased risk for suicide. Other precautions are related to adolescents and their cross-sex hormone therapy. These precautions may include cardiac disease, family history of abnormal clotting, smoking status, intracranial hypertension, metabolic syndrome, refractory migraine, seizure disorder, or strong family of breast cancer. Contraindications are generally more associated with adolescents who are leaning toward cross-sex hormone therapy or gender reassignment surgery. Before cross-sex hormone therapy, a medical and physical evaluation will need to be administered to rule out any contraindications relating to mixing of medications. Contraindications to cross-sex hormone therapy may include cerebral vascular disease, history of deep vein thrombosis, pulmonary embolism, estrogen-dependent cancer, and uncontrolled high blood pressure. The goal of gender dysphoria treatment is to address the distress and other negative emotions that are associated with having a gender that is in line with the assigned sex at birth. A typical course of treatment could last several years and include psychological and psychiatric evaluations, completion of the real-life test, administration of hormone therapy to create the desired secondary sex characteristics, and finally, sex reassignment surgery. Once puberty begins, a doctor may prescribe hormonal treatments that will delay the development of these secondary sex characteristics. Treatment is often given in 2 stages. Stage 1 involves the provision of puberty-blocking medication, while Stage 2 compromises cross-sex hormone treatment. Most treatment offered to children with gender dysphoria are often psychological help and support rather than medical or surgical treatment. This is because at this young age, children with gender dysphoria are much too young to make decisions on their own.
Occupational therapists should consider that although gender dysphoria in and of itself is not a mental illness, there are a lot of mental health components involved that may negatively affect children considering the comorbidities. Therefore, occupational therapists may work with individuals to address signs early on that may ultimately help children as they grow older. Ways that occupational therapists can help is by addressing stigma, promoting social emotional learning, including developing skill groups, focusing on bullying prevention, as well as collaborating with families and other health professionals to provide support and promote safe and healthy environments to address and prevent comorbidities. The following video shows examples of adolescents explaining childhood feelings and concerns involving mental health are discussed as well.
The young people at this support group are like any other teenagers, dealing with the challenges of adolescent life, but they also face struggles most don't. They're transitioning to a gender they were not born in, and that means a race against time.
I was constantly worrying so much before blockers that my voice would break or I'd develop really masculine features, and it wasn't healthy because I was worrying so much. That was my main worry, that suddenly I'd go through puberty.
I wanted to come out since I was 9, but I was an only girl in the family then, and I was like Mummy's little princess, and I didn't want to tarnish that, but my mum's had a baby girl and I thought, yeah, this is my chance, I can do it. So I did, and I've been really, really happy since.
I just kind of want to get it over and done with. I don't want to wait any longer than I have to, because once this is over I can live my life completely normally, like less blood tests, don't have to worry about people looking at me.
That's what you are.
Tallulah Eve Brown is a confident transgender woman with a rising profile in the community. But one of her big regrets is that she was unable to transition at a younger age.
More things like this when I was younger, I would have transitioned when I was younger because I would have felt more comfortable to do so. Yeah, I wouldn't have the Adam's apple and the deep voice. So yeah, I wish I could have transitioned younger.
Sky has obtained NHS England records, which reveal it carried out 330 gender reassignment procedures last year. Since 2002, the number of NHS male-to-female procedures has increased by 74%. There were only 17 cases involving 16 to 20-year-olds, but referrals to the UK's only children's clinic have gone up fivefold.
Not treating people is not a neutral act. It will result in harm. There are a number of studies around the world which report a greatly increased prevalence of self-harm and suicide amongst trans people who are unable to access care.
There's ongoing concern about the risks of medical interventions for transgender children.
To change sex is not possible, but we are administering cross-sex hormones, for example, not cross-gender hormones, and we're setting children on a path of medication for life, of very strong off-label drugs and surgeries which have complications and side effects, and we're sterilising children for life.
But as the agony of life in the wrong gender continues to be linked to depression, anxiety and even suicide, these young people feel it's a risk worth taking. Afua Hirsch, Sky News.
It is important to listen to individuals' experiences in order to gain perspective and help highlight concerns that are currently being overlooked. As shown in the video, mental health seems to be a major concern that isn't talked about until they are older. One study showed that the 3 most common associated difficulties expressed by individuals with gender dysphoria were bullying, with 47%, low mood or depression, with 42%, and self-harming, with 39%. It's important for clinicians to be mindful of the associated difficulties to consider what's important to individuals with gender dysphoria. By addressing bullying and providing support, in addition to other interventions previously mentioned, occupational therapists may help individuals manage with the transition early on and prevent or diminish any mental health concerns as they grow older. As OTs, addressing the psychological needs of those who have gender dysphoria should be a primary focus. During intervention, supporting the child and establishing supports within the context and environment of their meaningful occupations are critical components. It is a social aspect of how children with gender dysphoria are viewed by others and how their nonconforming actions may be negatively perceived that causes them clinical impairments within their occupations. If you have any questions, please feel free to write in our discussion thread.